The cardiovascular physical exam, it's so much more than just a checklist. It's really the first step in cracking some of medicine's most critical puzzles. Mastering these skills is absolutely essential, not just for taking care of patients, but for crushing your board exams. So in this explainer, we are going to break down the highest yield concepts to give you that diagnostic edge you need. Here's our game plan. We're going to follow the exact same systematic approach you'd use at the bedside. We'll start with inspection, move to palpation and auscultation, and then finish up with those dynamic maneuvers that can really clinch a diagnosis. And at the end, we'll wrap it all up with a quick review of the absolute must-knows. All right, first up, inspection. Your eyes are your first and maybe most important diagnostic tool. And when it comes to the cardiovascular system, the single most crucial thing you can see is the jugular venous pressure, or JVP. So what exactly is the jugular venous pressure? I want you to think of it as a living, breathing barometer for the right side of your heart. That little pulse you see in the neck? It's a direct window into the pressure inside the right atrium, giving us huge clues about cardiac function and a patient's fluid status. So how do we measure it? Well, the key landmark is something called the sternal angle. That's the little bony ridge on the sternum. From that point, you measure the vertical height of that venous pulsation. Now, if that height is more than 5 centimeters, that's a red flag. It's a clear sign that the pressure on the right side of the heart is way too high. And this is exactly why JVP is so important. An elevated JVP is never normal. It points directly to some major problems, like right heart failure or cardiac tamponade, where the heart is literally being squeezed by fluid. It could also mean constrictive pericarditis, where the heart is trapped in a rigid shell, or even just simple fluid overload. Basically, anything that jacks up the pressure on the right side of the heart is going to show up right here. Okay, so from looking, we move to feeling, palpation. This is where we use our hands to physically find the heart's position, and just as importantly, feel for any major abnormalities, like the powerful vibrations you can get from really turbulent blood flow. The first thing we're searching for is the point of maximal impulse, or what we call the PMI. This is that distinct little tap you feel on the chest wall with every single heartbeat. It's the physical proof of your left ventricle contracting and bumping up against the chest wall. You can literally feel the heartbeat at your fingertips. Now, the location of the PMI is a huge clue. Normally, you're going to find it right in the fifth intercostal space, along the mid-clavicular line. But what if it's not there? What if it's moved? A PMI that's shifted out laterally is a classic textbook sign of an enlarged left ventricle. The heart has physically gotten bigger, pushing its apex outward. While you're palpating, you might also feel this buzzing vibration. It's often described as feeling like a purring cat right under the skin. This is called a thrill. And a thrill is the physical sign of incredibly turbulent blood flow. It's a heart murmur so loud, we're talking a grade 4 or higher, that you can actually feel it. If you feel a thrill, you know you're dealing with significant pathology. All right, we've looked, we've felt, and now it's time to listen. Let's talk auscultation. Beyond the normal lub-dub of S1 and S2, the sounds that are really high yield for your exams are the abnormal ones, the S3 and S4 gallops. These extra sounds tell us a critical story about what's going on with the ventricles. Let's start with the S3 gallop. This is a low-pitched sound you hear early and diastole, right after S2. The classic way to remember this is the sound of blood hitting blood. Just imagine a huge rush of blood from the atrium slamming into an already overfilled ventricle. That collision is what makes the S3 sound. When you hear S3, you need to think volume overload. It's the hallmark sound of systolic heart failure. The S4 gallop is different. It's also low-pitched, but it happens late in diastole, just before S1. This sound comes from the atrium contracting really forcefully. That's the atrial kick, trying to shove blood into a stiff, non-compliant ventricle. The ventricle resists that filling, and that struggle is what creates the S4 sound. So the key takeaway here is S4 means a stiff ventricle, something you'd see with chronic hypertension or aortic stenosis.
All right, time for the advanced stuff, dynamic maneuvers. These are awesome techniques we use to change the heart's physiology just for a moment, which in turn changes how murmurs sound. Think of these as simple rules that help us figure out which valve is causing the problem.
The first and simplest rule is the respiration rule. When a patient takes a deep breath in, that simple action increases the amount of blood returning to the right side of the heart. So more blood flowing across the right-sided valves, the tricuspid and pulmonic, means any murmur coming from them will get louder. It's a really simple but powerful way to tell right-sided murmurs from left-sided ones. But of course, in medicine, there are always exceptions. And these two exceptions are famously high yield for exams: hypertrophic obstructive cardiomyopathy, or HOCM, and mitral valve prolapse, MVP. These two murmurs do the exact opposite of almost all the others. Maneuvers that decrease preload, like the Valsalva maneuver where you bear down, make most murmurs softer, but they make HOCM and MVP louder. And then squatting, which increases preload, makes most murmurs louder, but it makes HOCM and MVP softer. Okay, let's bring it all home and lock it in with a final high-yield review. If you are prepping for an exam, this is the slide you really want to pay attention to.
Let's recap these core connections. You see an elevated JVP, you're thinking high right-sided pressure, period. You feel a displaced PMI, that's left ventricular enlargement. You hear an S3 Gallop, that's volume overload, the classic sound of systolic heart failure. You hear an S4 Gallop, you're thinking stiff ventricle, probably from chronic hypertension. And finally, if a murmur gets louder with Valsalva, the two things that should pop into your head are HOCM or MVP. These are the diagnostic links that are going to make all the difference.
See? Mastering these physical exam findings really does transform you from a student into a clinical detective. So let's put your new skills to the test right now. You hear a murmur that gets louder with inspiration, and you hear it best at the left sternal border. What's the most likely cause? Drop your diagnosis in the comments below, and if you're ready to master more high-yield topics, make sure you subscribe.